Actually, we are today talking, can I start?
Yes, sir, please, looking forward to
Like
it.
we are talking on measurables, and I have been given the topic target OPD. And let me tell you that OPD is the doorway to the whole hospital. So essentially, OPD is a very important place to understand everything, and that's where things happen. Now, we have an appointment system which gives 5,000 appointments every day across 18 branches, and 20% dropout, 20% are filled in by walk-in patients. So generally, this is the usual story, everyday story, or the history of our hospital. Now, what does an appointment system does vis-a-vis Aravind, which we saw, is it definitely helps in time management, and it helps in on-time service. I think singularly this has become the biggest content of today's service. Nobody has time, so we must be very impromptu in our service timings. So this is one thing, and obviously nobody likes a lot of people waiting. It gives waiting times. You have to explain why waiting, keep them occupied so that it feels less, explain them why you are waiting, and occupied waits and all kinds of things you have to treat. Waiting time itself is a managing waiting time is itself a challenge by itself. And of course, if you see a patient quickly, the patient will go to the spectacle outlet, will buy medicines, will go for investigations, or will take the dates. I mean, the other compliance of the follow-up of the consultation will be done properly. So appointment systems, even if you are seeing 5 patients a day, please develop an appointment system for yourself. There are huge systems which function in a different way, but that is their competence. What happens is, in appointment systems, if the systems are overloaded, 50% appointments are usually old, 50% are new. So the old patients are generally who would come up, the follow-ups. So they can be scheduled in non-prime times. I mean, a continuous effort can be made in that direction. Like post-op spectacle appointments are important because you get a low-hanging fruit, a spectacle. So, don't overcrowd your spectacle counter by giving, say, a busy surgeon does 20 appointments, surgeries a day, and give it all in one time. So all the 20 just go to the spectacle section and crowd it. So these are little nuances of how to deal with them. And obviously the next follow-ups, the investigation. Suppose the patient's take an injection, or there's an OCT review after 1 month. So he does the investigation, then comes to the consultant, which saves time again. So these are little things we've been following. And of course, choosing the second half OPD, OT balancing, these kind of things are required. And evening OPDs we usually keep for high-end, VIPs and some complicated cases who've been referred from or have moved across 10 centers, want something concrete. So at that time, over a cup of tea, we can have a medical board, that kind of a thing. Now, scaling up, I would rather say to people who have come here, with our kind of charges, about 300-400 rupee in the OP. The usual scaling up is till 30 patients. You should confine yourself to your only small clinic. Go to a surgery center, send your patients for diagnostics to some diagnostic center, work with an NGO or with us or any other center, and try to cross that barrier of 30 patients before you really start your proper hospital chamber. Because without these critical numbers, it doesn't kind of work in financial calculations. I'll come to that later, and then you go ahead if you're growing, suppose you are 25 patients, but you are growing at 20%. So the next year you are 30 patients. So, I mean, these things you have to take into account. And between 30 to 70 is a wonderful number where you can, if you're having them on a regular basis, you can definitely plan your own setup. And between now it becomes a multiplication, and sometimes there'll be economies of scale, sometimes there'll be diseconomies, because suppose something between 90 patients will be a diseconomy, but 60 70 will be a very good economy of scale. So now here, when you have 150 patients, today that the entire concept's becoming hyper local, people want it closer to home. Whether you should have a second center or a higher center, or you want a replication of the first center, is something that you need to trade off. So that's what I'm saying, that with 250 patients, you can have a VROT, and above 400, it is a 9-doctor. So essentially, it's a 50 patients a day. If the doctor is seeing at the end of the year, if he's seeing around 15,000 patients, I think that is a good target OPD for a good consultant work. I'm not saying about fellows or trainees. Now, this is a OPD cost is a place where most institutions lose money. You know, to get one cataract, you would understand you will spend 3,500 rupees just to get a cataract surgery. In subsidization, almost every OPD is subsidized except Ritika's OPD. And subsidized to the tune of, say, 300 400 rupees. So 15 patients, you eventually end up spending 3,500 rupees in the OPD to get a cataract. So that is a preliminary cost for cataract. Please add to your cataract cost, Ritika, because that's what you are going to speak on. So this is a primary cost. If we were talking, having a discussion on the camps, I think the same formulas also apply to camps. Yes, sorry.
Last slide, why is not changing? The doctor's cost.
The doctor's cost. No, I mean, the doctor is, it's 150 rupees per patient. So essentially, that's what not changing. The variable cost and the other costs will be divided by economies of scale. So, this is, we have a culture in our Disha that a macula is best seen by a OCT. So our OCT numbers, and we do it for 300 rupees. Now, if your OPD cost is low, just understand what does a patient spend in the OPD. He is comfortable spending a 1 day's income, 1 day's per capita is a comfortable spend. It could be in South Delhi, it could be 10,000 rupees. In our situation, it is 700 rupees. So that is what he is comfortable. So if you have 200 rupees, you add a OCT, or you add some medicines, you add a spectacle. So all that fits into his spend, and he is comfortable. So OPD, our numbers are every 10th patient gets an OCT. So, I mean, if you are seeing 150 patients, there are 15 OCTs. So that's how you recover the costs. ASP and DFP, I'll tell you what, give a photograph of a BRVO or even a cataract and say, this is the cataract. The patient's been going to 10 doctors. I can see everything. Everybody's saying, I need an operation. Now, humko photo de diya cataract wala. So that is more convincing. So use these devising tools. And if you keep what I'm trying to say is keep the basic consultations low and fit in these investigations. Ultimately, the patients get more satisfaction, and you also get these services, and you are more authentic in your delivery. So these are the list of other things. We do Optos. We use Optos in a center of 300, and we use it as an indirect ophthalmoscope. So this is the Optos thing at 300, and the calculations are 500 patients, 50 patients per day. You get at least 10% myopics. So all myopics go to Optos, 250 days, 300 rupees, and 38 lakh yearly recovery. So, I mean, you can even increase it to 600, so you just need 250 patients. Now, I will not go into OPD costs because that is Ritika's area. But what I'm trying to say is, unless you are seeing 30 patients, when you are seeing, the number of cataracts that you would expect is 400 a year. And the surgical cost of the center would be, if you take the lens, 2,500 will be 11,000 rupees. Whereas in 8,000 rupees, you get good surgery centers to operate for. So why would you spend it? Doesn't become that. So at 50 patients, probably, you hit that bullseye, and you should be investing in a surgery center. So sorry, I mean, that was Ritika's past. This is again the same thing, so I'll skip that. Now, going into the doctors, how do we actually compensate for us? Like, say, Aditya Bajaj has a compliance ratio of 78%. What I'm trying to say is, somebody may be sprinkling cataract advices, so his compliance will be low. And somebody who is talking to the patients and really getting into him will probably advise 60 surgeries, and 40 of them will convert. So he has a better compliance ratio, and we compensate that. We talk to them also, and we compensate that. So that waiting time also, we for consultants, because it is big money, everything is titrated. Intervention ratio, brand, waiting time, number of patients, number of surgeries, spectacle conversions, medicines you prescribe, everything. So because I'll explain brand later. So this is how, if you are red, you get only 50% of the 150 or 200 rupees. If you are green, you get 100%. So that is it is 30 minutes, 45 minutes, 1 hour. So this is how we manage things. And of course, these systems help in automated, targeted giving out to their WhatsApp or to their emails specific information which help in second eye conversions, or in lasers and injections, and reminder follow-ups, calling for second eyes. Now, explain you about the branding thing. Now, when we give appointments, we ask, do you want a specific doctor, or you have a problem? What is your problem? Do you have a specific doctor in mind? Says yes. So it becomes a brand for that doctor. Now, we communicate that with the doctor. After 5 years, the doctor is given a choice whether he wants to be a brand doctor or whether he wants to be a general pool Disha doctor. Now, when he becomes a brand doctor, he gets 30% more, but he doesn't get Disha patients. So he can work more, work less, earn more. So that's the little things, nuances that I had to share in this 10 minutes. Thank you.
Excellent, sir. Absolutely mind-boggling. I think I have no words. You have covered absolutely everything. I wish we could have, on each slide, we could have had a complete 10 minutes on each slide rather than the entire talk on 10 minutes. Dr. Ravindran, sir, your comments on that.
No, I was just telling him his talks are always unique. You made a great presentation, and there is a lot I'm going to ask him after the talk.
So one question before Dr. Ritika can please come. So regarding the appointment, you said you'll give 5,000 appointments in a day. Like you said, even if you have 5 OPD patients a day, you give appointment. For 5 OPD patients, is easier. If you have an OPD of say 200 or 300, then don't you think each patient who has been given an appointment?
Telephone appointments would be around 60%. Huh? 2,000, 3,000.
So
And
my question
the
is,
rest of the patients, when they go, the second appointments, like the 50% would be follow-up appointments. So they take some, the family members come to show somebody else's eyes. They take somebody else's appointment. So in-person appointments are about 40.
so the question I had was, many times when an appointment is given at say 10 a.m., the patient usually turns up at 10:15, and then the next appointment gets delayed.
No,
Plus,
we have the other problem. They usually come much before. It depends like how much distance they travel.
but don't they, because once they
For
get
our
dilated,
centers, usually they travel 20 to 30 kilometers to avail our center.
so the expectations of patients are they need to be checked at the time that they have been given appointment. So for example, if there has been some patient waiting before that, or there have been walk-ins whom you obviously you will not send back.
Yeah, in a center there is a culture, so they know what exactly is the culture of the place. Because most of the place patients are recruited word of mouth. It is that they don't want to waste time in the hospital. I mean, they feel that it's a waste of time, especially the person accompanying the patient.
Yes.
Patient is an old man or an old lady, fine with her, but the person bringing him, he doesn't have time. Shreyash doesn't have time.
So to keep up the appointment sometimes becomes difficult, especially if they have to do OCTs and dilatation and repeated consultations.
I mean,
So the more time they
we need to
spend,
plan all of that,
all of that. Yes.
and that is where multiple functions, knowing multiple functions for staff, etc., etc. The more flexible we are in the delivery system, better it is.
So
One way to address your thing is, if you can get additional information about the patient, about the age, systemic status, whatever investigation they have done earlier or consultation they had. If all of that they are able to upload into your system, then you can also allocate the time accordingly.
right,
So, yeah.
that's a good idea. Thank you so much, sir.